Nadine was very modest in saying, she'd helped a little bit in sort of changing the legal landscape. We sort of very much feel that our work at Birthrights is very much founded on Nadine's case, and it's made such a contribution to the work that we do and to the work in this field. So it's a real privilege to follow you, and thank you so much for taking that case forward. Okay, so I've called my talk today Caesarean Birth, Exploring the Limits of Choice in Childbirth. I'm going to talk about a campaign that we did last year, culminating in a report last August on maternal request caesarean. And the reason I've called it Exploring the Limits of Choice in Childbirth was because this campaign really turned out to be probably the most controversial thing that we've done as an organisation. And it was quite interesting to see people that we knew supported women's rights to make choices in childbirth, whether that was around home birth or free birth or abortion, but who found this choice particularly difficult. So what I thought I'd do is spend the first part of my talk explaining the results of a Freedom of Information campaign that we ran. And then for the second part of the talk, I'll maybe provide a bit of food for thought and hopefully for discussion and debate about what might lie behind those results and what it says about what's happening in maternity care post Montgomery, and how the law can help us define where the choices might lie in childbirth. But first, I'd just like to tell you a bit about the Birthrights itself. For those of you who haven't heard of the charity, our aim is to improve maternity care through a focus on human rights. And I always feel when I'm discussing this topic, I should make clear that as an organisation, we don't support or judge any particular choice. We support women who make all sorts of choices in childbirth. And for me, this quote from an American birth activist called January Harsh really sums up what we're about as an organisation. It says, "I do not care what kind of birth you have, a home birth, scheduled caesarean, epidural hospital birth, or if you birth alone in the woods next to baby deer. I care that you had options, that you were supported in your choices, and that you were respected. And as an organisation, that is what we want to see in maternity care." We have a number of strands to our work. We run an advice service for women and for healthcare professionals. So if anybody in this room, or if you know anybody who feels that they might come across a scenario when they're not quite sure what their rights are in relation to human rights and how it applies in maternity care, they're very welcome to contact our advice line. The address is info@birthrights.org.uk. We also train many healthcare professionals through some formal training delivered with trusts and local maternity systems, and also through coming to speaking engagements like this, to raise awareness of what the obligations of healthcare professionals are under human rights law. If anybody would like more information, we've got leaflets on our stand out in the foyer. And we take the intelligence from our advice service and from the training that we do with healthcare professionals, and that feeds into our campaigning and research work. And I'm going to talk about one of those campaigns now. So as I knew that I'd be following Nadine, I thought it might be appropriate to use another quote from the Montgomery and Lanarkshire judgment. This quote says, "Societal changes suggest an approach to the law which, instead of treating patients as placing themselves in the hands of their doctors and then being prone to sue their doctors in the event of a disappointing outcome, treats them so far as possible as adults who are capable of understanding that medical treatment is uncertain of success and may involve risks, and accepting responsibility for the taking of risks affecting their own lives and living with the consequences of their choices." And when we talk about Montgomery and Lanarkshire in our training courses, we talk about the fact that it represented the law catching up with what was already good medical practice. So you'd be forgiven for thinking that the NICE guideline on caesarean was actually drafted after the Montgomery case, whereas in fact it was drafted or revised 4 years before. But it contains a lot of the same ethos about treating women as individuals who are capable of making their own choices. So what the NICE guideline on caesarean says is that if a woman requests a caesarean without any other indication, then the medical professional should discuss the overall risks and benefits of the choice of caesarean compared with vaginal birth, and bring in others if appropriate. They can bring in other members of the obstetric team, or if the request is driven by anxiety, then it's appropriate to offer perinatal mental health support. But the key thing is that if the woman continues to want a caesarean section, she should be offered one. It's also important to note that the guideline contains an explicit protection for obstetricians who feel uncomfortable carrying out those sorts of caesareans. So it says that an individual obstetrician can refuse to carry out a maternal request caesarean, but they should refer the woman to an obstetrician who will. So our reason for starting this campaign was because we felt we were getting a lot of inquiries into our advice line of women asking about their rights for maternal request caesareans, and also some concerning stories, particularly about women being written to after booking into care and being told that that hospital or trust wouldn't offer this option before they'd even met with a healthcare professional, but had told them at the outset that that wasn't an option on offer. So what we wanted to do was find out how widespread that issue was. So in order to do that, we conducted a freedom of information campaign. We wrote to all the clinical commissioning groups in England and all the trusts or health boards in England, Scotland, Wales and Northern Ireland. And what we were trying to find out was how many caesareans they'd carried out over a year period for maternal request, and how they approached implementing the NICE guideline and what information they gave to women about their approach on that. We got a really high response rate, 91% of CCGs replying and 97% of trusts replying, so really good sample. And this is what we found. We started with CCGs mainly because we'd had some anecdotal evidence of women saying that healthcare professionals had said they wouldn't be able to offer this option because the CCGs wouldn't pay for it. Actually, what we found out was that was perhaps less of a problem than we expected. So what we found from the Freedom of Information request was that 26 CCGs had a policy that was explicitly unsupportive of maternal request caesarean. Most CCGs said that they would leave it to the trust to decide. And that these tended to exist in clusters where there was a kind of wider area policy where maternal requests might be on a list of treatment of low clinical value. And these are some of the areas where we found that cluster of CCGs with an unsupportive policy. But overall, probably less of an issue with the CCGs than we were perhaps anticipating. The trust results, on the other hand, were quite surprising. What we found was that we felt that only 26% of trusts had a policy that we felt was in line with the NICE guidance. So that they had a policy that was explicitly in the spirit of the NICE guidance, and they had a written policy. Although it's not a requirement to have a written policy, we felt that gave some indication that it was applied on a fairly consistent basis. The largest group of trusts we classified as amber. We felt these were trusts where there was some indication that maternal requests would be offered, but we weren't entirely clear whether women would get one in the end. And these included trusts that required 2 consultants to say yes to give a maternal request caesarean. They included trusts where an appointment with a perinatal mental health professional seemed to be mandatory. They included trusts that wouldn't make a decision until very late in the pregnancy, so after 36 weeks, which is very anxiety-provoking for these women. They included true trusts where they wouldn't schedule the caesarean until after 40 weeks, which is really just playing Russian roulette about whether that's actually going to happen or not. Okay, so that was the amber trusts. We actually found 22 trusts that had a policy of not offering maternal request caesarean. Now, this doesn't necessarily mean that women wouldn't get a caesarean in those trusts, but what they had was an explicit policy written which they either gave to women or had as a policy, that they didn't offer maternal request caesarean. And the rest of trusts we felt didn't provide us with enough information to be categorised. So those are the results of our campaign, and it's now, it would be good to open up to some discussion and some thought about what might lie behind that. So Nadine referred to a comment that Baroness Hale made in the judgment from Montgomery in Lanarkshire, talking about vaginal birth being morally preferable to caesarean birth. And I think it's important to acknowledge that a lot of people feel that way. And perhaps there are understandable reasons for that. After all, midwives are trained to facilitate physiological birth, and obstetricians are, taught that their role is to intervene where there's a problem, perhaps rather than intervening when they don't see that there's a problem. But we really need to drag out those reasons and look at that gut feeling and see what lies beneath it, and see if it really stands up to scrutiny as a reason for restricting a woman's right to make this choice. And I just thought I'd go through some of the reasons that we've heard for people saying that this shouldn't be offered. The first is cost, and this comes up frequently when we discuss this subject. And it's true that as a base cost, caesarean does cost more than vaginal birth, around £700, according to NICE. However, NICE also did a sensitivity analysis of that economic modelling, and they took into account the costs of treating urinary incontinence, which is one of the longer-term impacts that can result from vaginal birth, but only one. And they found if they took that into account, the cost difference was only £84, which they didn't see was enough of a cost difference to mean that women shouldn't be offered that choice. And in fact, new research has come out very recently that looks at what happens if you take litigation costs into account. This research by Jonathan West, Taylor and Michael Magro has looked at the costs of planned caesarean section versus planned vaginal birth if you take litigation into account. And it's published on the F1000 research site if anybody wants to have a look at it. And what they found that if you take litigation costs into account, caesarean birth actually looks very cost effective. It's actually £439 cheaper. And in fact, that difference could grow considerably over time. So on the face of it, cost doesn't seem to be a very good reason for refusing maternal request caesarean. But perhaps the most common reason given for refusing maternal request caesarean is that it's not believed to be in women's best interests. Perhaps we come back to that paternal attitude that was referred to in the Montgomery judgment. And I'm probably not best placed to give a critique of the evidence, but I would, if you allow me, to plant a few seeds of doubt about the quality of it. I think it's generally acknowledged that the quality of evidence around maternal request caesarean is actually very low. And that's because most studies that have looked at this issue take both emergency caesareans or unplanned caesareans and planned caesareans and look at the outcomes across the piece. Whereas in fact, we know that the outcomes or the risks of emergency caesareans are going to be higher. The other common mistake in this area is to compare a caesarean birth to a vaginal birth, which isn't really the correct comparison. Of course, if you're heading for a vaginal birth, you've got a number of outcomes that might come about. First of all, you might have a straightforward vaginal birth, but you also might have an instrumental birth, or you might have an emergency caesarean. So you're really looking at that bundle of risks compared to the risks of a planned caesarean. The other thing to note is that the risks of those bundles are not entirely clear-cut. There was a meta-analysis published last year in the PLOS journal, which looked at 79 cohort studies and one randomised control trial, which in total looked at 30 million cases, and concluded, drawing on evidence from NICE, that the short-term adverse associations of a caesarean delivery for the mother, such as infection, hemorrhage, visceral injury and venous thromboembolism, have been minimised to the point that caesarean delivery is considered as safe as vaginal delivery in high-income countries. So, looking at short-term outcomes, there's really not much to say that caesarean is more dangerous. There are also long-term outcomes to consider, and these are particularly relevant for women who are going to go on to have future pregnancies. And there are also mixed evidence about long-term outcomes for the baby as well. So, those have to be taken into account, and those should be presented to women in an evidence-based way. But we perhaps have a bit of a simplistic discussion around these issues when we talk to women about them, where caesarean is seen as bad and vaginal birth is seen as good. Whereas in fact, of course, there's risk to vaginal birth as well, as we've heard from earlier in the day. And in addition, the risk will differ considerably depending on what the person who's in front of you and her individual circumstances. So if you have a 42-year-old woman whose risks of perineal trauma or damage are going to be higher, and she's not planning any future pregnancies, that's quite different to talking to a 23-year-old woman who's planning to have a large family. So, safety, yes, there are some risks, but it's a bit more of a nuanced discussion than is perhaps sometimes presented. So other reasons for restricting this choice that have been put to me are that it puts obstetricians in a difficult position, and there's a pressure on them to carry out an operation that they don't feel comfortable with. I can only say that as an organisation, we have been contacted anonymously by obstetricians who feel that their right to practice as they wish and to give personalised care is being restricted by their trust policy not to offer maternal request caesarean. But I have yet to speak to people who feel that they're under real pressure from a trust to do the opposite. And indeed, the NICE guideline explicitly offers a protection to obstetricians in that position. Finally, the other reason I've heard for restricting this right is around theatre capacity. The argument being that this takes theatre space away from women who might need an emergency caesarean, which could potentially be a justifiable reason for restricting this choice. Although it's hard to see how that works out in reality. So we've had a long-running correspondence with Oxford University hospitals about their policy on maternal request, and this was the reason that they gave us for restricting their offering of maternal request caesarean. So Oxford is a hospital that has just under 7,000 births per year and a caesarean rate of around 27%, so just under 2,000 caesareans a year. And yet Oxford argue that this policy affects 4 to 5 women. It's sort of hard to see how 4 or 5 women are going to make a massive difference to theatre capacity. But that's what they say. So, are there good reasons for restricting this choice? I'm not sure that there are, and I think a lot of it probably comes back to this cultural unconscious bias, which is then translated into restricting the choice. So what are the implications of this offering only being offered consistently by a quarter of trusts? The first thing to look at is the implications for women. These are some quotes that we've received as an organisation from women who really feel that they've had to fight to get a maternal request caesarean, and in some cases have been refused one. And it really doesn't establish any trust or a good relationship between the woman and the care team that are going to be looking after her. And of course there are implications for that woman's mental health and her well-being for quite a long time for the birth and afterwards. It's really important that we understand a bit more about why women make this choice as well. And from what we found looking at this area was that there was a poor understanding about why women made the choice, and a lot of assumptions about it being down to a mental health issue. Whereas in fact, from the women who've contacted Birthrights, the highest reason for women requesting a maternal request caesarean was having a previous traumatic birth. And the second highest was having some kind of underlying medical condition which didn't meet the threshold for a medical caesarean, but was nonetheless of huge concern to the woman. So we've looked at the implications for women, but there are also implications for trusts as well. And this is where we come back to looking at whether the Montgomery case has made a real difference in terms of trust recognising women as the primary decision maker about their birth. So at an organisational level, if trusts are going to restrict this choice and go against NICE guidelines, the onus is really on them to explain what their rationale is and why it's different to what NICE considered. It's interesting to consider what the legal implications might be for a trust who refuse a maternal request caesarean and then the woman goes on to be harmed. It's also important to consider what information we're giving to women who are asking for this choice. The risk is that cultural bias towards vaginal birth leads to confirmation bias, whereby women are given information that supports what the clinician already thinks, perhaps that caesarean is a bad idea, and are not given balanced information about the risks of vaginal birth as well. And so we feel that caesarean birth should not be easily dismissed as a reasonable option and should be properly discussed in line with NICE guidance. Just to leave you with a bit of hope, we do think it's perfectly possible to come up with a guideline that both respects women as the primary decision maker about mode of birth, but also takes into account some of the concerns of healthcare professionals. And on our website, we've got a blog post about Birmingham women's policy on maternal request caesarean, which we think represents good practice. In this guideline, it talks about recognising the woman as lead decision maker, and it uses language such as, if the woman has decided on caesarean section, at every appointment reconfirm, not challenge her decision. And it makes clear that the decision should be made earlier in pregnancy, between 24 and 28 weeks, allowing the woman to enjoy the rest of her pregnancy with that anxiety hanging over her. Finally, I just wanted to use the opportunity to publicise a couple of things that are coming up for birthrights over the next month. They both happen to be on the 18th of June for some reason. So on the 18th of June, we'll be publishing a new report that shares some research that Birthrights has been doing with birth companions about the maternity experience of women facing severe and multiple disadvantage. It's going to be a really interesting and useful and insightful piece of work, so do look out for that. And also on the same day, the consultation on coronial investigations into stillbirths ends. As an organisation, we have some concerns about the proposals, but we think it's really, really important that as many women and families affected by this respond. So I know many of you will work with women who've perhaps been affected by a stillbirth. So we would encourage as many people as possible to respond to that consultation. That's all from me. Thank you very much.